Good morning, everybody. Welcome to Pediatric Grand Rounds. We're so excited to have those of you who are here in the room and also all of you who are on WebEx with us today. Just the usual reminder for our WebEx folks, make sure your microphone is off, your camera's off if you want it to be off. If you have questions or comments for the speaker at any time during the presentation, you can type them in the chat and I will read them out with my microphone. And now I get to turn things over to Dr. Amy Trowbridge, who's going to introduce our speaker and our lectureship for today. Thank you.
Thanks so much, Suzanne, Dr. Mazer. It's an honor to be here and to be able to introduce the Mann family Pediatric Palliative Care Grand Rounds. The Mann family, Barbara and Eric Mann, have generously supported the hospital for a really long time, and specifically the Bioethics and Palliative Care program since 2007. Their support has allowed us to do some really fun and creative things for specialized education and training that hopefully many of you in the audience and many more have benefited from some of this training that the Mann family has supported. One of the things that the Mann family supports is this yearly lectureship, this Grand Rounds, and we are super thankful to them for that. And with that, I'll introduce this year's Mann family Pediatric Palliative Care Grand Round speaker, Dr. Jennifer Walter. Dr. Walter is an associate professor of pediatrics at the University of Pennsylvania, Perelman School of Medicine, and an attending physician in general pediatrics and pediatric palliative care at the Children's Hospital of Philadelphia, or CHOP. She's also the director of medical ethics at CHOP. Dr. Walter completed an MD and a PhD in philosophy at Georgetown University School of Medicine. Since her training in both medicine and philosophy, Dr. Walter has worked at the intersection of clinical practice and bioethics with an emphasis on the physician-patient relationship and family-centered communication. Her current research focuses on facilitating and improving communication between the healthcare team and families of children with serious illness. With funding from the National Palliative Care Research Center and the National Heart, Lung, and Blood Institute of the NIH, as well as the Cambia Health Foundation, she's developing interventions that we'll get to hear about today to better train interprofessional teams in collaborating and communicating better to improve outcomes for patients and families. Now that I've read all that, I'll just add my own personal note to say that Dr. Jennifer Walter is the real deal. In addition to all of the incredible work she has done, she's also an incredible mentor, a national leader in our field, an inspiration for women in medicine, women in ethics, women in palliative care, and a dear, dear friend. Please join me in welcoming Dr. Jennifer Walter.
She's going to make me cry. One can only be so lucky as to have the opportunity to mentor and be mentored by Amy Trowbridge. So congratulations to all of you who get to work with her on a regular basis. Today I am excited to share with you my work on interprofessional team interventions to improve communications with families of children with serious illness. I have no disclosures. I'd like to echo the thanks to the Mann family for this generous opportunity. And start with 3 objectives for today's discussion. First, I want to describe an intervention and some recommendations to improve communication with families of children with chronic critical illness, and look at the evidence base for interprofessional team training to achieve improved patient and family outcomes. And finally, to help you interpret the acceptability, feasibility, and impact of an interprofessional team training to improve family meetings in the cardiac intensive care unit. It's always helpful to start with the patient story. This is an amalgamation, but we can imagine a patient, Keela, who's now 11 months old, born very early at 26 weeks, developed chronic lung disease as a result of her prematurity, spent about 8 months in the NICU, was able to be discharged on non-invasive respiratory support, meaning something like BiPAP, and was home for a little bit before she got rehospitalized into the pediatric intensive care unit, where she's now been for about 4 weeks with acute on chronic respiratory failure. Her mom is starting to get frustrated with the team's communication with her. The team is worried that Keela's going through a lot. Her mom doesn't really understand everything Keela's having to go through because mom has many other responsibilities, including work and other children, which prevents her from being at the hospital all the time. And there's now some disagreement within the team about whether we should really push the mom to consider tracheostomy, something she'd previously tried to hold off on doing when they were in the NICU. And so Keela is what we would call now a chronically critically ill child, someone who has spent extensive time in the ICU, will have repeat ICU visits, and has ongoing medical technology needs. This category of chronically critically ill patients disproportionately are utilizing ICU resources. They are staying longer and longer and coming back over and over again. The families of these children are really at high risk for conflict with the team around decision making. Within the team, there's disagreements about how to manage these patients. Parents experience lots of stress, anxiety. We see increased rates of depression. And the team experiences a lot of moral distress in caring for these patients. And we don't really have a good approach for how to manage them. The ICUs were built for caring for really acutely ill kids that got better pretty quickly, and now these kids are staying for months. So I, along with some colleagues, tried to develop some interventions and have worked also with others to do best practice recommendations for what to do for these families. And one thing that repeatedly comes up when you talk with clinicians who care for these kids is they feel like they're stuck. They're stuck in some cycle. We can't necessarily figure out what the best clinical plan for them is. We don't always know how to support the parents in decision making around advanced technologies. And so we end up having the stays that are already sort of long end up longer because the team's attention is drawn away from these sort of chronically ill patients who are not immediately trying to die constantly to the kids who are trying to die constantly, right? So they kind of get left behind in the day-to-day working of the ICU. And so we thought that if we could add an additional attending to the team that provided continuity for these patients over longer periods of time, that we would be able to maybe help get some of these challenges unstuck, right? We'd be able to facilitate more efficient decision-making and better communication with families to reduce the distress the team and the families were experiencing. So I don't expect you to be able to read all of this, but our protocol for this intervention was to identify patients who'd already been in the PICU for 7 days and they anticipated they would be there another 7 days. At that point, we would randomize them either into this augmented continuity care intensivist or they'd continue along with usual care. In the intervention arm, they'd be assigned a continuity intensivist, someone who had volunteered to be part of this intervention. And they would meet with the family weekly at least, the team weekly to discuss the team's planning. And then hopefully, if there were family meetings or more frequent group discussions, that person would be there. And they would stay with the patient throughout the entire ICU hospitalization. In the usual care, there was sometimes people would get assigned a intensivist that would stay with them, but when that would happen, what it looked like as they did it, as what we hear from many other institutions, wasn't standardized. We really hoped that we would be able to improve things like decision-making and length of stay in the ICU, but when we looked at our data, we actually didn't find any difference in length of stay for these patients. And we also didn't see any other patient-level outcomes that we had hoped to impact, like reducing hospital-acquired infections or making decisions around things like tracheostomy more efficiently or days on mechanical ventilation. So we unfortunately didn't see any improvements in the patient-level outcomes. What we did see, the beginning of a story, was that when we asked the attendings who played this role of the continuity care intensivist, and we asked the normal rotating weekly service attendings what they thought of this intensivist that provided continuity, everybody thought that things were going more efficiently. Like the perception was, all the green bars are agree and strongly agree. Over 80% of clinicians thought that having this continuity intensivist was actually improving the experience of decision-making, happening more efficiently, and that it improved the care they provided. So what we started to think about is how are these teams that are really working with highly acute patients and have a lot of turnover, what is the ability for them to communicate with each other? And there was, around the time that we were publishing these results, another important review of ICU communication, and it really showed that communication within the team was hanging by a thread. That they felt that healthcare providers rarely took time to meet together and reach consensus about things, that they weren't trained to deal with these complex and big picture issues that these complex chronically ill patients had, that there was a lot more within team conflict about how to handle these patients for those that stayed over a month, and et cetera. And so even though the evidence base wasn't great, there was a push to come up with some kind of recommendations and best practices based on clinical experience and the limited data that was there. And so I was invited to participate in this effort led by Jeff Edwards to really think about what would continuity strategies for these long-stay patients look like and what should it include. And so this group endorsed the idea of a primary intensivist, even though we didn't have a positive study to demonstrate it impacted patient-level outcomes. But the goal was really to try and have this person meet regularly with the family and the team to support decision-making and to ensure consistency of communication. In addition to the need for primary intensivists, there also was a recognition of the need for primary nurses, that this strategy could provide consistent care, that the nurses would then be more empowered to participate actively on rounds on a daily basis, bringing the expertise they had from the longitudinal care, and that they could help ensure consistency of orienting new nurses to the patient. And finally, there was a recommendation for what they called multidisciplinary meetings, and I would call interprofessional meetings, that on a weekly basis, we would have a meeting that would include things like a discussion of the patient's trajectory and current treatment plan, what the family needed, what their goals were, and the opportunity for the team to have a discussion around what they really thought the best practice was for moving forward with the patient so they could reach consensus, because there was not always agreement about that. So at this point, I sort of shifted the focus of my research to thinking more about this interprofessional team and the kinds of meetings that they were being encouraged to have. And for all of you clinicians, this interprofessional teamwork component is really all the times that we meet as a team without the family, right? How is it that we're working together? How is it we're pulling in the expertise of different team members? And so this seemed like an important element that maybe was overlooked with respect to this type of communication. And so I wanted to have a better understanding of what the evidence base was for team training, whether or not we could achieve this, and then what we would train people in. So I went to the literature, and luckily there was some really nice review articles that demonstrated that teamwork is actually very effective. Optimal teamwork positively impacts performance and improves patient outcomes. This was a review of over 30 papers looking at teamwork in healthcare. And so, great, if we could get a team to be high functioning, it could improve patient outcomes. Well, can we train the team? Luckily, there was a meta-analysis of over 109 studies that demonstrated that yes, we actually can train whole teams, that we can train not only trainees, but we can train actively practicing clinicians. We can do it in high acuity settings, that they can learn things, they might even enjoy it, and that, believe it or not, they're going to change their practice and improve patient outcomes. So I think that there was enough evidence base to think that it wasn't crazy to dive in and see if we could build a team training to improve how teams communicated with families and family meetings. So I went to all of the literature around best practice and collaborative practice and interprofessional practice. National Academy of Science, as well as the IPC, had a whole bunch of recommendations and guidelines, but guess what? All the stuff they covered didn't in any way necessarily address how we communicate as a team with families in these types of planned meetings and high acuity settings. And so that left me with the question of, well, what do I train people in? And how do we do it? So I went to thinking about a conceptual model. A lot of the literature around successful teamwork was in the safety world. And what we thought about was that for the teams that wanted to achieve like good, high reliable, effective care, that they started to implement things like checklists in the OR to ensure that all of the sort of elements were done appropriately and in the right order. And that these types of processes that were implemented for teams helped achieve the outcomes that were the outcomes we wanted to, sort of make sure happened on a reliable basis. What I had been hearing in the care of the chronically critically ill child was that it wasn't just providing good care to these patients, but it was like, how can we do it effectively as a team that doesn't get exhausted, burnt out, and all want to quit, right? Like, how do we do this in a sustainable way? And so we started to think more about some team outcomes, and the team outcomes being that the team functioned in a way that led to like full team satisfaction with their job and their role, that they felt like they were collaborating together to achieve care of the patient, and that they were more likely to stay in their job and keep doing it because they felt like they were being heard and valued. And if we were going to try and achieve these team outcomes, which I think is reasonable to argue would help also achieve the patient and family outcomes, right? If we have a healthy team that's like still got the energy to like dive in and deal with these challenging patients, like we're better off, the patients are better off as well. And so, yeah, I mean, you have a great interprofessional team as well. And so we started to think about what part of what we need to do is also develop these within team or team processes that would help ensure that the ability for the team to continue to function, that they'd maintain this energy and resilience was something that we had to be intentional about, and that what kinds of processes could we put in place that would help elevate all members of the team and include them in a meaningful way. And so one of the practices that was happening inconsistently was this idea of having a team meeting before they met with a family to try and really center these ideas around what is going to happen and to really hear the different voices on the team about their perspectives. So I'd done all this background work, and now I was ready to dive in and start observing and then building. And so I was lucky to be able to partner with our cardiac intensive care unit at CHOP to start observing family meetings and the preceding team-only meeting or pre-meeting huddle. And so I dove in with my study team. We did a lot of audio recording and collecting data. And then I also realized that to build something to help be successful at implementing an intervention, we needed to really harness the expertise of not only clinicians in the cardiac ICU, but also parents of children who'd been hospitalized there. And so we invited 15 clinicians. There were attendings, nurses, a social worker, and a psychologist, as well as 6 parents of children who had been hospitalized in the CICU to really help us design. And the idea of co-design is that we learn from the experiences and expertise of the people who will actually be implementing or experiencing the intervention so we can tailor it to their needs. And that what we've learned, the world has learned, not just me, but I've also experienced it, is that what we get is much more willingness to implement the intervention and utilize it because people are invested in its success. They've helped build it and they understand why it's doing what it's doing. And I could not have done this without an incredible group of cardiac ICU colleagues who are interprofessional themselves, a social worker, a nurse who was a clin supervisor and now is a nurse manager in the unit, attending colleague, and then a CNS nurse researcher colleague who were really essential to both helping me think through how to present information to the co-design group, as well as interpret what they told us and like really translate that into intervention elements. So I want to express my gratitude to them. So what did we hear? What did we hear from both the background work we were doing and observations, and how did we harness that for the intervention? Well, one of the first things we heard is that parents' experience of what it's like to be told you're going to have a family meeting is that there's like no consistency in what we explain to them that means, and that's confusing, overwhelming, and often very anxiety provoking. And so we recognize that the best way for us to support families in preparation is to like actually prepare them consistently and do it with something in print that they can review. So we created sort of like a combo questionnaire and handout where we described the purpose of the meeting, as well as what family meetings are, what they can request, meaning who they can ask to be present, both their loved ones that they trust, as well as if they want the team to check in with a clinician that they trust. And then an opportunity for them to collect their thoughts and prepare their questions. So what do they understand about their child's illness already? What is keeping them in the hospital? What other concerns do they have? What's most important to them knowing this about their child's illness? And then also assessing the parents' communication preferences, right? Are you a big picture person? Are you detailed? Like, how do you want to learn information? And so the first element that came out of this intervention that we ended up calling CICU Teams and Loved Ones Communicating, or CICU Talk for short, was that we needed to have parent preparation for the family meetings. Also, in looking at how the conversations were going when we observed them and looking at what best practice has been described, Doug Opel being one of our experts in shared decision-making nationally, what we were actually doing in our communication with families is that we were often just like talking at them. We didn't do a lot of listening or assessing what was important to them, or helping them parse out which of the plans was most consistent with what was important to them. And so we needed to really train and educate clinicians about how to have those types of conversations, and that was going to require actually simulated role play communication skills training, like Dr. Trowbridge is doing with the Vital Talk here at Seattle Children's. And so this was an important part of what we wanted to give every clinician the skills to be able to do. Going back to that, like, team health and well-being and like, is everyone being heard? We had learned about sort of this fancy concept of shared decision-making within the team, something that was described by a couple colleagues here at UW, including Randy Curtis, where the idea of laying different options out on the table, weighing the risks and benefits, and thinking about what's best for a family also happens before the conversation with the family, right? The team itself needs to weigh the different potential options, and the more we're able to be inclusive of all the expertise on the team, the more successful it could be. When we observed the team meetings, we didn't see a lot of interprofessional shared decision-making happen. I did some additional work with our oncology colleagues around the decision about whether to involve subspecialty palliative care in a care team for a sick patient. And we heard a lot of barriers to being able to really have this interprofessional shared decision-making process work. And so given the fact that our physicians were dominating these pre-meetings with talking like over 80% of the time, and we heard from the other subspecialty clinicians that there were lots of challenges for asking for, a care plan, like adding palliative care because of concerns of hierarchy or uncertainty by the other team members. And so we realized that there was work to be done here. And so I actually came out to Seattle many years ago now to work with Dr. Trowbridge and others that were running the graduate certificate program in palliative care to try and understand an incredible teaching module that they had already developed, which was called Team Talk. They were teaching interprofessional team members how to communicate with each other and how to be supportive of the sort of minoritized perspective. And we thought, this is exactly what our team needs. We're going to take a model that you've built and we're going to add it into the intervention as an important part of communication training. Oops. We also realized that when we looked at family meetings that there were many missed opportunities. Families weren't actually speaking very much in these meetings. Somewhere between 5 and 20% of the conversation was with the family speaking. And that wasn't just in our ICU, it was actually across the board in all the pediatric ICU studies that we found. Parents were rarely asked how much information they wanted. Their knowledge of their child's condition was almost never assessed before they were given new knowledge, and that there were just a lot of opportunities that we could improve upon when we looked at sort of how to best communicate with families. And so we thought that maybe if we prompted the team with a outline for how to communicate in a family meeting, they could do better, right? Remind them, introduce yourself, set the agenda, ask what the family already knows and what they want to know before you just dive into giving them information. So again, our co-design team thought that it'd be really helpful to have just-in-time resources that would be provided to the team so that they would be ensured not to skip many of these important steps. And families also said, there's so much information that's discussed in these meetings. I'm overwhelmed. I don't remember it all. Holy moly. And so we thought, well, why don't we write it down for them, right? This isn't rocket science. But if we have a clinician that actually acknowledges sort of who was in the meeting and then goes through 2 or 3 agenda items that catalogs that, it can be really helpful for families. And so those elements became the component of our intervention that dealt with best practices in conducting family meetings. We also realized that there was real variation in whether that pre-meeting happened and what it included. So we tried to standardize that by also ensuring that we had a non-physician who ran the meeting to, again, decenter the physician monologue that was happening. And that we wanted to really encourage people to achieve certain elements in that very brief pre-meeting where they discuss what the actual agenda items they were planning on talking with the family about, and to the extent that the family had had the opportunity to prepare, and in our case, the social worker was the liaison between the family and this team meeting, the social worker would bring back to the team meeting what questions the family was likely to ask. There would be an opportunity to use all that communication skills training that we'd given them so that they could practice what they were going to say to the family in advance, particularly if there was something really difficult to discuss. That the team would be sure that they had all the right people there, and if the family had asked that they also speak to their, beloved nurse or their, sort of primary cardiologist, that they would be able to check in with that person potentially before a meeting or acknowledge at least their importance. And then review again from the social workers, communication with the family, what the family's communication preferences were. And importantly, also to start to think about what roles they'll play in the family meeting. And so this pre-meeting work was really intended to demonstrate how the team should be in parallel with the family preparing for the family meeting. And one thing that we noticed was happening, because the physicians were speaking most of the time, is that they were actually also doing all of the different roles that could be really separated and articulated independently. And that both was sort of driving why they were speaking so much, and also really a burden for them, that they would be happy in some circumstances to have the support of their colleagues in doing some of these roles so that they could focus on what was often a really challenging communication of new information or an update about the patient's well-being. And so we were able to articulate 4 independent roles that were intended to be played by different team members, although sometimes one team member could do more than one, and they were not specific to any particular professional role. So the idea would be that many team members could serve the role of facilitator, where they're setting the agenda for the meeting, ensuring that you follow that outline, and then maybe handing it over to other team members to provide information that the meeting is intended to convey. But because they're not doing both of those roles at once, they're able to keep, a big picture view on how the meeting is running. Also, we thought it was really important to name, acknowledge, and have the whole team recognize the importance of someone who's really keeping their finger on the pulse of the emotional space of the meeting, right? When family is getting overwhelmed, that they have the authority to pause, to sort of slow down the conversation, acknowledge that this might be really overwhelming, and check in with the family. Like, should we keep going, or do we want to sort of end here in terms of in allowing for the best ability to communicate? And then finally, that summary worksheet was filled out by one of the clinicians, so someone was asked to be the documenter as well. So those elements became how we provided role clarity for the team and the family meetings. And then finally, the people that were like thoughtful educators pushed us to say, well, that's all and good. You're going to train them in these things. They're going to use some of this, but how are we going to keep pushing them to improve and like continue to build skill? And what we sort of learned from our educator colleagues was that the best way to solidify some skills is to do a debrief after a sort of family meeting, where within just 5 minutes, like, they reinforce what went well, talk about how they could do better in the future, and try and provide some feedback for each other. And that was the last element of our intervention, the debrief. So it's a big intervention. There's lots of pieces. And the hope was that we would be able to sort of both give people the skills and the processes they needed to be optimally successful. So my last objective today is to talk about the acceptability and feasibility of this intervention. And we did a pilot study in our cardiac ICU where we implemented the intervention, which we were able to do. And then we collected the same type of data as we collected pre-intervention of observing family meetings and surveying clinicians and families, and also doing acceptability interviews to try and capture their perception of the experience. We were able to enroll 22 clinicians in the ICU. There was a group of about 10 intensivists who typically were the ones who ran these meetings, and we were able to include all 9 of the 10. We had about 8 nurses, and these was the category of nurse that typically attended the family meetings because they weren't in the bedside role, but like served in this sort of support and education role. We had all of our social workers in the unit enroll, and we had 1 NP enroll. As you can see, their years in practice was actually variable. It wasn't like we just got the junior people. We got people at multiple different levels in their sort of clinical practice to be willing to do the intervention. And they all completed all components. And that was 8 hours of training that included both synchronous and asynchronous training. It was implemented during COVID, so we had virtual simulated role plays for communication, but they all completed all the elements. We had like an assessment at the end that they learned what we taught them, so like a little quiz to ensure that they knew where the resources were and what to do. We were also able to enroll and collect data on 30 parents, both in the pre and the post intervention data. They're different families, and we in the family meetings we had an average of about 2 parents that were able to participate in the family meetings, with about 2/3 in both sessions where both parents were present. And just so you have like an idea of what the family meetings looked like, we had on average 4 clinicians in the family meetings. There was always an attending. There was almost always a social worker. There was always a nurse in the pre-intervention, and less likely during the post-intervention because we had such a strain on nursing during the COVID pandemic. And we had to really work with the nurse leadership to ensure that they could have a nurse present for many of those meetings. And we really heard from the clinicians, like they felt the loss of that nurse presence when they weren't able to be there. So how did we do? Like, what did we see? So this was a pilot study. It wasn't powered to necessarily detect differences, but we did look at several outcomes. And for the pre-family meeting huddles, we were curious about what kind of impact we may have had on the teamwork component. We used a validated tool that was used in the team safety literature, which measured 5 different domains of teamwork: the team structure, leadership, situation monitoring, mutual support, and communication. What we were able to demonstrate was a significant improvement in all of the domains once we implemented this intervention. Teams were communicating with more sort of team focus. The structure of the team was much clearer to identify, and they were much more supportive of each other, which is really exciting. And those came from, like, again, scoring audio recorded and transcribed transcripts of the meetings. When we asked the clinicians what they thought of participating in these meetings, the blue is strongly agree, the green is agree, and then the orange is disagree. Overwhelmingly, the clinicians said the training was effective, it was enjoyable, it provided them useful skills. Everyone said they would recommend it, and over 80% said they think it should be compulsory for other clinicians in the ICU, and that they were using the materials and that it was sort of beneficial to them. We did interviews with the interprofessional colleagues to hear from them what their experience was actually implementing the intervention with real families. We heard that the structure was beneficial. A clinical nurse said, we've been doing these meetings for a long time, but the intervention helped provide structure and helped to get everyone on the same page and be better prepared for when we meet with their families, better prepare the families for what they would expect in these meetings. There also was a real acknowledgement that the intervention empowered particularly the non-physician members of the team and allowed for all the teams to kind of think flexibly about how they could be doing their roles. And so again, one clinical nurse said, in previous meetings, I've always felt like I've been in the background, but this helped empower me. I should be part of this conversation actively. And attending acknowledged sort of the expansion of their vision of what they're doing in a meeting by saying, we were talking about the idea of a trach and that she might need it. But then we spent a lot of time talking about what a strong family they were, what a strong baby she was, and they walked out feeling hopeful, even though they got this really difficult news. The importance, again, from the clinicians of shared language. The intervention helped to ensure the team knows the agenda and goals, as well as communicates in the same language for family, understanding and ultimately facilitating a smoother family meeting. And then, again, acknowledgement of the importance of that nurse involvement. There's a reason why we involve multiple providers to this meeting. So when there's not nursing presence, there's a gap in knowledge. So just even being able to articulate explicitly that importance of the interprofessional team as they're preparing for and conducting these meetings. So what did we see in our family meetings? Well, in the family meetings, we were looking to see, can we move who's speaking? Can we broaden the pool of interprofessional colleagues that are contributing to the meeting? What are we doing to really elicit more information and concerns from the family? So we looked at the proportion of words spoken. We asked about whether we, again, coded for how many times questions were asked of parents, how many times the team elicited parental concerns, and how many times the team elicited questions from families. In our bivariate unadjusted models, we saw that there were some increases in a couple of these measures that are outlined in red. And when we moved to multivariate models, we still saw statistically significant increases in the number of times that the team would elicit parental concerns, trying to engage them in the conversation. There was almost 3.5 increased odds that they would do that in the post-intervention. None of the other, again, measures were statistically significant in multivariate models, but we have trends in the right direction for most of these, and given it was a small sample, I think it's promising that we'll be able to demonstrate some improvement in later studies if we have a larger sample size. And then we asked the parents about what they thought about their exposure to the intervention elements, which included that worksheet. We surveyed parents about that, and 80% of them thought that it had about the right amount of information and the right kind of information, although some did say it had a little too much information for them. And we also asked them about whether they thought other families should receive these types of materials in preparation for a meeting, and 80% agreed, with another 20% being neutral. No one thought it was harmful, at least. And then when we interviewed parents and asked them about sort of more in-depth information around these tools, when they talked about the preparation worksheets, they acknowledged that it actually reduced their anxiety about having a family meeting. One parent said, "It gave me a very good idea of what they were going to talk about because, as I said, first we were a little confused, a little scared, but then reading the worksheet and how the social worker made it sound comfortable for us. So it was kind of good, put us at ease." And then their response to receiving the summary worksheet, we were hearing that it was perceived to be a helpful reference for them, that they looked back on both when talking to their other family members that hadn't been present, as well as when they reviewed what was going on with other team members afterwards. One parent said, "It was definitely helpful so that I could review what they said because there was a lot of information. So I'm sure I didn't retain everything in the moment, but it was good so that I could go back and my husband could see it since he wasn't there in person but had just called in." So we are glad that families experienced that. So what are some of our next steps with this work? We have already done work actually with neonatal ICU clinicians and parents of children who've been hospitalized in the neonatal ICU to sort of do the co-design process again to make sure that if this clinical setting and sort of type of experience is different for those patients, how can we make sure this intervention captures what they would need as well? And then we acknowledge that all the work we've done up until now was with English-speaking families. It's like the low bar, but that what we really owe families is to try and expand the population with which we can support their communication. And so we've worked with a team of bilingual people to help translate this into all the family-facing pieces into Spanish. And then the goal in the next steps is to try and actually culturally adapt it for people with a range of different experiences with how they want to communicate with clinicians, and to pilot test it in the NICU so that we can then eventually move on and do a larger efficacy trial in both the NICU and the CICU with English and Spanish speakers. There are many, many team members that I want to thank, Dr. Trowbridge included, for helping support this work. It is truly a team effort. I'm happy to take any questions, and here's the Grand Rounds evaluation slide. We love your feedback anonymously as well.
Thank you. All right, for those of you online, type away and I can read your question out if you have one. And if you're in the room, I'm happy to bring you the microphone.
Dr. Walter, that was fantastic. And kudos to studying this topic because it isn't easy, I know, but it's really, really important.
Thank you.
My question for you is how we define teams. And as you know, they are constantly changing. They're very dynamic. Do you imagine as you test and scale this that it's really the unit that you're thinking of as a team? Mm-hmm. And
yeah,
as you think through that, there are still smaller teams within that unit that will then be functioning in this way. And how do we accommodate rotators like palliative care coming in and joining it, or ethics or other specialty services who haven't received this training? That would be helpful.
Excellent question. So I went and studied with the organizational behavior people to try and understand everything they knew about teamwork, and they were really frustrated with my constant point that, like, we don't have a stable team, right? Most of that literature is defined by, if you have a stable team, this is how you build. And basically what we saw in the study, and I didn't show this data, is that if you have enough processes in place with prompts, and you have at least one or two team members who did the intervention training and kind of feel confident in ensuring this process is moving forward, we can still achieve the elements of the intervention. So we had something like, 70% of the post-intervention meetings had a attending that had been trained, but there was still 30% where there weren't. But in those meetings, we had a social worker or a nurse who had been trained. And we had the prompt of, this is how you're gonna do the family meeting. And we had a prompt for this is what you're gonna discuss before you go in the family meeting. And those processes with at least one team member who could advocate for or support the fact that this was part of the process was something that was able to maintain enough of the intervention elements for us to code it as faithfully meeting the intervention as intended by protocol. We did have palliative care attend a handful of the meetings. We had many other subspecialists. I didn't show this slide because it just is so overwhelming, but we had something like 115 clinicians that rotated through the team and the family meetings. And I only trained 22 physicians and 9 physicians and 22 people. So yes, you're right. And I think that that's why it has to be so comprehensive, the in time supports that are provided so that people can feel okay, I'm going to let the facilitator run this and I'm just going to roll with it,
Thank you so much for your presentation. Kind of similar to that question, I have been part of conversations like this in the PICU and the NICU, and the team comes away, and what appears to be we come away with a goal or some sort of endpoint, and then 2 days later, a new nurse or a new RT or someone else comes and receives an emotive cue from the family and says no one has talked to this family, and it kind of adds to that, I think, moral distress of the unit and of that team interdisciplinary team structure. Are some of these documentations, has there been thoughts of is that part of the patient's chart? Is it something that people can go back to see what things have happened to kind of inform them of where we are at as a team, to then inform their relationship with the family, that day's clinical picture, et cetera?
What a great question. I can't tell you how many ethics consults we get from that exact scenario of only some team members have actually the information around what's been discussed and the moral distress that ensues from the rest of the team. So yes, the whole part of the other idea of providing this written clinical summary to the family is that it gets scanned and put into the electronic health record. Part of that is okay, but are people looking in the media section for the family meeting summary? But what we realized is that if there's not palliative care present, sometimes the social worker has time to write a summary of what happened. Oftentimes, the attendings got one line, had family meeting, discussed trach, right? But you have no idea what exactly happened in the conversation or what the next steps are. So the hope would be that the time spent on sort of communicating to the family in clear English, what was discussed, what the next steps are, would also be available to all the clinical team members in the electronic health record. But if you guys use Epic, people aren't used to looking in the media section. So then it takes a culture shift of how do we train everyone? The other thing we did do is we basically, once we realized that the bedside nurses, just even with invitation, wouldn't come, we would send them the video link where you can log in on your phone at the bedside and hear the conversation, even if you're not able to make it to the room where this family meeting is happening. And that way we minimally maybe improved nursing participation. They didn't all take us up on it, but it seemed like it was a feasible thing to offer to them, was that they could listen into the conversation and then share that information in their sign out.
That was awesome. Thank you so much. with kind of adapting this for different ICU contexts, are you planning for when you roll it out in the NICU to get that buy-in for the design changes, or are you planning on using the same design for a different unit and just kind of learn about some of the differences? I only ask because, as you know, there are huge differences in how things are done between the units, and I'm in PICU, and we have such a wide variety of things that come up for us as opposed to the NICU that
Totally.
I'm just curious. Thanks.
Great question. So we actually convened a NICU and a PICU co-design group. We got attendings, nurses, social workers, chaplains, and what we were hearing from the PICU group is they couldn't even focus on the family meeting. They were like, it is so complicated. We've got all these subspecialists. This is totally different. This cardiac world is so narrow. You've got one set of subspecialists more or less that are the primary external people. The PICU is too many people. We were working with the same group of neonatologists, and they're like, we can see how we can adapt this. And so we did get their buy-in for which elements we would change. Not that many, to be honest. Our CICU is filled with neonates. We have a lot of neonates that end up getting cardiac repairs earlier in their life. And so I think that similarity is making the adaptation for the NICU more viable, whereas the PICU really is. It is a really different environment. So I paused on the PICU adaptation. Well, if you want to partner, you can you can help me.
Thanks again, Dr. Walter, for this presentation. I've been thinking a lot just about culture change in communication and in interprofessional relationships. And I wonder if you have thoughts either from your data or just sort of anecdotally about how this has changed the relationship amongst these team members outside of these family meetings, the way that maybe communications happens with family at the bedside, or the way that rounds happen, or any sort of outside of this very specific one place. I imagine there's ripple effects.
That was the hope, right? Is that if we get people to act differently, they start to think differently, they start to act differently because of a different reason. They really believe that this inclusion of other voices is meaningful. What I can say is more anecdotal rather than what I've studied, but when talking with the social workers on the unit, they're just so grateful that we have implemented something that gave them sort of an opportunity to showcase their expertise in the work that they do with families, that it doesn't all happen siloed at the bedside alone, just between the social worker and the family, but that the team really relies on them more. I think that we've had a lot of turnover with this nurse group because of the pandemic, and so a lot of the nurses I trained in the intervention are now nurse managers. So they believe in it. They want their new nurse people to do it. But I think that because there's been more continuity for the team members that went through the training with their colleagues, that their day-to-day experience has really been sort of transformed. And there's more of an awareness of the importance of it and the inclusion of other team members on the unit and more day-to-day communication as well. Yeah.